let's get right into it. Today, we're tackling a clinical puzzle that shows up all the time: normocytic anemia. You know the situation. Your patient's anemic, but when you look at their red blood cells, they're a totally normal size. It's one of those things that can make you scratch your head. But the truth is, all the clues you need are right there, if you know where to look. So let's put on our detective hats and start the investigation.
So, you get the lab report back. Hemoglobin's low. Okay, that's clear. But the MCV, the size of the red blood cells, is sitting right in that normal range, between 80 and 100. It's so tempting to just kind of look at that and think, well, normal size can't be that big a deal, right? But trust me, that's a classic trap. Normocytic anemia can be the first sign of anything from a hidden bleed to a serious bone marrow problem. So the real question is, what is your very next move?
Here's our game plan. We're going to start with the single most important test you need to order. From there, we'll split our investigation down two very different paths. One where the bone marrow is working overtime, and one where it's kind of fallen asleep on the job. Then we'll pull it all together into a super practical algorithm, and we'll finish up with some killer pro tips to add to your clinical toolkit.
And that brings us to our first major clue. This is the diagnostic crossroads, the one test that's going to crack this wide-open case into two much more manageable pieces. It guides your entire investigation from this point forward. And that critical test is the reticulocyte count. So what are we actually looking at here? Well, you can think of reticulocytes as brand new, baby red blood cells that have just been kicked out of the bone marrow. So by counting them, we get a direct look at how hard the bone marrow, our body's red blood cell factory, is actually working. Is it seeing the anemia and cranking up production like it's supposed to, or is it just sitting there, not responding when the body needs it most?
And this, right here, is the fork in the road. A high reticulocyte count tells us the factory is working just fine, maybe even in overdrive. So the problem isn't production, it's that we're losing red blood cells somewhere out in the body, either from bleeding or destruction. But a low count? Uh-oh. That tells us the factory itself has a problem. The bone marrow isn't making the cells we need.
Okay, so let's follow that first trail of evidence, a high reticulocyte count. The factory is pumping out cells like crazy. This immediately narrows our list of suspects down to just two main things. Either the patient is bleeding somewhere, or their red blood cells are being destroyed faster than they can be replaced. Let's make this real. Picture this. A 45-year-old is rushed into the ER after a bad car accident. They look pale, their heart is racing, you're pretty sure they're bleeding internally. So you draw a quick CBC, but the result that comes back, well, it might just fool you. Now here is an absolutely crucial clinical pearl, something that trips people up all the time. Right after a big bleed, the hemoglobin and hematocrit can look totally normal. Why? Because you lost whole blood. You lost the cells and the plasma in equal measure. It's only after a few hours, when your body starts pulling fluid into your blood vessels to compensate, that things get diluted and the hemoglobin value actually drops. And that factor of response, the big spike in reticulocytes, that doesn't even show up for 2 or 3 days. You have to do serial checks. Okay, on to our second suspect in the high retices category, hemolysis. This is the active destruction of red blood cells. So let's take this case. A young woman suddenly feels awful. She's tired, her skin is turning yellow, her urine is dark, and it all started right after she began a new antibiotic. That whole picture should be screaming hemolysis at you. And what's so cool here is that just looking at the peripheral blood smear can give you incredible visual clues. You see these little, dense, perfectly round cells called spherocytes? That points you towards autoimmune hemolysis. What about cells that look like someone took a bite out of them? We call those bite cells, and they're classic for G6PD deficiency. And if you see these fragmented, torn-up red cells called schistocytes, that's a huge red flag for mechanical destruction, maybe from a bad heart valve or a deadly condition like TTP. So, here's the bottom line for this path. If your reticulocyte count is high and you're thinking hemolysis, get a haptoglobin level. Haptoglobin is a protein that acts like a sponge, mopping up the mess from destroyed red blood cells. If that level is low, it's because it's been all used up cleaning up a big hemolytic mess. It's a massive clue. All right, let's back up and take that other path. What happens if the reticulocyte count comes back low? This means our factory isn't responding to the anemia. There's a production problem. And now our job is to figure out why. The one you are going to see all the time, by far the most common cause in this category, is anemia of chronic disease, or ACD. This is that stubborn, low-grade anemia you see in patients who have long-term inflammatory conditions, like rheumatoid arthritis, a chronic infection, or even many cancers.
So how in the world does something like inflammation cause anemia? It's actually a fascinating process. As this slide shows, that constant simmering inflammation makes the liver pump out a hormone called hepcidin. And hepcidin is basically a jailer for iron. It locks iron away in storage cells and blocks it from being absorbed. So the body ends up with plenty of iron, but it's all locked up in jail, where the bone marrow can't get to it to make new red blood cells. It's a functional iron deficiency.
Now we have to talk about something much, much more serious. If you have a low reticulocyte count, you absolutely must look at the other cell lines on the CBC. If the white blood cells and the platelets are also low, what we call pancytopenia, you could be dealing with aplastic anemia. That's complete bone marrow failure, and it is a true hematologic emergency.
This right here is a rule you need to burn into your brain. If all 3 cell lines are down and the bone marrow isn't even trying to make new red cells, you have to assume the marrow itself has failed. Period. This patient needs an urgent hematology consult, no delays.
And another huge cause of underproduction is chronic kidney disease. The reason why is actually super straightforward. Healthy kidneys produce a hormone called erythropoietin, or EPO for short. EPO is the chemical signal that tells the bone marrow, hey, make more red blood cells. When the kidneys start to fail, they stop making enough EPO. The signal gets weaker and weaker, and the factory just slows down. Okay, we've covered a lot of ground and a lot of different culprits. So now, let's put it all together. We can take all this information and synthesize it down into a clean, simple algorithm that you can use every single time you see a patient with normocytic anemia.
Here's your playbook. Step 1, you confirm there's an anemia. Step 2, you note that the MCV is normal. Step 3, and this is the big one, the game changer, you get the reticulocyte count. If it's high, your brain immediately goes to blood loss or hemolysis. If it's low, you pivot your investigation to underproduction. Think chronic disease, kidney failure, or a primary marrow problem. And the final step, always, is to put the lab results together with the actual patient story.
So, to bring our investigation to a close, let's boil all this down into some final, high-yield clinical tips. These are summarized from the work of Dr. Yogesh, and they really crystallize the most important takeaways for your daily practice.
Here they are, fast and to the point. 1. That reticulocyte count is always your #1 next test. No exceptions. 2. Want a quick screen for hemolysis? Check for a low haptoglobin and a high LDH. 3. That classic lab pattern for anemia of chronic disease? High ferritin but low serum iron. And 4. Don't forget, patients can have more than one thing going on. Your patient with kidney disease might also have an iron deficiency. Always think about mixed causes. And this last piece of advice is maybe the most critical of all. If you are even a little bit worried about the bone marrow itself, especially in a patient with pancytopenia, get a bone marrow biopsy. Do not delay. It is the definitive test that can provide life-saving answers. So when you boil it all down, this entire seemingly complex diagnosis really comes down to these 3 big buckets. Is it an underproduction problem, where the factory itself is the issue? Or is it an increased destruction problem, where you're either breaking cells apart through hemolysis or losing them through a bleed? Your reticulocyte count is the key that tells you which door to open first. And that's our case file on normocytic anemia. Now you have the algorithm, you know the clues to look for, so the next time you see that CBC result pop up, you'll know exactly how to solve the mystery. The only question left is, which hidden clue are you going to spot first? Thanks for joining.